and welcome to the show. Now we're starting a new series which will be a regular feature on the show. It's called The Scope, and in The Scope we'll be looking at the science, the medicine, the business and the politics of all things to do with healthcare and well-being. I'm joined by our resident expert, Professor Frank Sullivan, a radiation oncologist with the Galway Clinic. Frank is here because Frank is also my husband, so I thought it would be a very good idea to get his expertise on medical and well-being and healthcare issues over the coming weeks and months. Frank, you're very welcome to the show. But first, one of the reasons I really want to talk to Frank today about is this controversy over the public-private contract. As you know, the government, the state took over the private hospitals. When the COVID pandemic emerged, they were very nervous that they would be faced with a huge crisis in the public hospitals and they wanted extra capacity. But that has created a lot of problems because many of the consultants in the private hospitals did not want to sign the contract that would make them work in this system. You have been one of the doctors, Frank, who's been speaking out about this. What is the situation now with that contract?
Well, look, we're recording this on the 17th of May, so I can't believe it's been 2 months really since this phase of the epidemic has come through. On the 1st of April, this announcement was made that the government had taken over effectively all control of all the private hospitals in the country. Now, casting our mind back to that time, one can readily understand why they would have wanted to do that. At that point, we were facing a possible meltdown of the entire health system, including the intensive care units in our hospitals. So obviously there was, where that was a concern, it was entirely appropriate that they reached out. The problem is, like everything, in the manner in which this was done has left us with lots and lots of problems. And we've been highlighting those over the last couple of months. And they have meant that many doctors like me have found ourselves effectively blocked from doing work in any hospital because of the arrangements that were put in as part of this takeover.
Okay, tell me what the main problems have been.
So the main thing was an insistence that the physicians work on a public-only contract, which would require us to effectively stop our work in our rooms or in our outpatient departments, if you want to call it that.
Stop all private work with private patients?
Yeah, because we are working in private hospitals, yes, it would stop anything but the work in the hospital directly assigned to us by the public system. Now, look, many of us would have been well ready to jump in and do our work in conjunction with the public system at any time, but the route they chose led us to have to basically shut our rooms. And there was no understanding initially given to that as an issue. And certainly for me, day one, for me to close my outpatient rooms would be to walk away from 3,500 cancer patients that I have followed for 15 years.
Why would that have been the case?
Because, as you know, 2.2 million of the Irish citizens have private health insurance, which means they seek their care from people like me in hospitals like the Galway Clinic. Doesn't mean that they don't often also go across to public hospitals for other reasons, but the bulk of their care is delivered through our network. And the bulk of that care is actually delivered in the outpatient setting. We only bring people to the hospital when there's a specific requirement for an operation or procedure, radiation treatments, chemotherapy, whatever it might be. But the bulk of my practice I do in my outpatient rooms. And I pay for those rooms, I support them myself. So giving me a salary that looks after me in the hospital is not enough because it wouldn't allow me to keep going with my rooms work. And that's why I couldn't sign it
because you would have a build-up of expenses that you would have to carry yourself.
Effectively, I'd be insolvent because the amount of money that was coming to me from the salary wouldn't cover my room's expenses. And without going into all the detail on that, you know, I was not alone. Anybody with rooms, anybody with outpatient clinics, which is most of us in the private hospital system, you know, we're in the same boat, are in the same.
And as we heard as well from some consultants who've been speaking out, some of them have very high expenses, high medical insurance and maybe mortgages on their rooms as well. But why Didn't the Department of Health, the government, the HSE agree to pay your expenses?
You'd have to ask them that. I really don't know, because it makes no sense. If they had any concept of trying to keep everybody working to full capacity, then they would know we're not going to walk away from our outpatients. You know, it's unethical. I'm sure the medical council would have something to say to me for that, if I was to abandon effectively the guts of my 3,500 patients in favour of work, important work in the hospital. But it can't, we felt it couldn't be done at the exclusion of that. So I don't know why they didn't offer that up from the beginning. There are plenty of ways they could have chosen to operationalise this that would not have raised this as an issue. For example, they could have offered us a contract that would allow us to keep going in our rooms at our own expense, and those contracts exist. But there was no consideration for that. And I was part of a deputation that went to see, in that it was a virtual meeting. The Minister for Health and the Department of Health senior officials just last Friday, Friday week actually, and we made that point to the Minister and to the Department of Health and asked them, pleaded with them really to consider another way to do this, and there was absolutely no willingness to change.
And what has the effect been on all of this, on your patients and on patients generally who would have gone to these private hospitals?
It has been devastating for people. I think that's not an exaggeration to say that. Let's start with the patients, the most important people. They woke up, you know, from their COVID hibernation, if you will, to find that the only healthcare services they'd ever known were effectively shuttered, or could be shuttered. So they've been ringing my office, and I'm sure all my colleagues are getting these calls on a daily basis saying, what's going to happen to me? Where do I get my treatment? How am I going to be? Will I have to go to the public hospital, and so on? And we really had no good answers for these people. So the main effect has been on our patients. And I suppose that's compounded by our insistence that, you know, we had to stop work for 2 months for obvious reasons because of the COVID crisis. But we know, I'm a cancer physician, we know the cancers aren't stopping their growth or progression. And every day that we're not dealing with them is potentially a day when a patient's care might be compromised. And that could lead to a poorer outcome, maybe a later stage of the diagnosis, or maybe a delay in the treatment which would affect the outcome of that treatment. And sadly, for some people, it might cause some patients to lose their opportunity to have their cancers cured and may present too late for that. You know, so that's a real disaster. Me and many of my colleagues have been saying openly, look, we need to get back to work and we need all guns blazing in this phase of our recovery. And why on earth would we have chosen a route that takes 600 senior medics out of any phase?
Okay, but around 300 or over 300 have actually signed the contract. So clearly a big block of private consultants have felt it is going to work out for them because they signed it.
Look, I respect that and I understand it. And I can tell you, because I felt this myself, there's been a fair bit of pressure put on us to sign that from a variety of sources. And some of my colleagues, for whatever their particular reasons, you know, have had to go ahead and sign it. Nobody did so enthusiastically, and those that signed, I would say by and large, and I don't want to generalize here, but by and large they may be doctors who don't have outpatient clinics, for whom that was not an issue. For example, certain clinicians operate exclusively within the hospital environment. I'm thinking about maybe pathologists or radiologists, certain radiologists, or maybe you know, anaesthetists, for example, who clearly don't have outpatient rooms. They operate entirely in the hospital. And I could quite understand that some of my colleagues, for obvious reasons, who don't have that burden of an outpatient room would say, look, you know, I need to get back to work, and they would have taken it.
Okay.
But I would say to you that the bulk of the high volume surgical specialists, some of the cancer specialists, not all, but people who do all of the endoscopies, people who do the diagnostic work, the bulk of those, at least in my hospital, and I think it's true to a greater or lesser extent across the country, have not signed for the reasons I alluded to.
And we have the odd situation where actually the state took over the private hospitals, so there was no more treatment of private patients in a private setting. And yet, ironically, private patients can still be seen by their consultants in the public hospitals in a private capacity. You tweeted about this morning. You said, paradoxically, the only place a patient can be treated privately is in a public hospital. Meanwhile, private hospitals, 2/3 are empty. How has that really odd situation emerged?
Well, look, I mean, I'm on record as saying we have one of the most complicated, interdependent health systems on the planet, I'd say, in Ireland. So, you know, we would all love to have a single-tiered system which had the capacity and the expertise and the facilities and the throughput to deal with the entirety of healthcare. We'd love to have that, but obviously we don't. It's well documented that we've had significant queues and waiting times to access care on the public side. And maybe as a result of that, over the last 50 years, the private market jumped in to fill that void. And so, you know, a hybrid system exists in Ireland. And by the way, a hybrid system exists in many European countries. It'd be relatively rare where you'd have either an entirely private system, such as the US, or an entirely public system.
So the different systems, but how did it happen that at a time when the state was taking over the private hospitals, it still enabled private patients to be seen in public hospitals privately?
Yeah, that one is down. That one is down to the fact that we have a blinding array of different working relationships in the country. So there are some doctors like me who work exclusively nowadays in the private system. I spent many years in the public system, and for 10 years was primarily involved in the public work. But now I happen to be exclusively in the private side at this stage. But there are plenty of my colleagues who have contracts that allow them and require them to be in the public hospital, but allow them to also do private work in the public hospital and private work in the private hospital. So there's several hundred, maybe several thousand consultants who have that kind of working arrangement with the government. And for that reason, since they've now designated the private hospitals as, in quotes, public hospitals, and have forbidden any private work to be done in those settings, ironically, consultants who can work privately in the public hospital can continue to do that. Yes. So it's led us to this paradoxical situation where private patients can only now be treated in the public hospital.
It seems really weird. No wonder people want a single-tier healthcare system where you'd get rid of all those anomalies and everybody can see whoever they want when they want.
I know how this works, and I have trouble explaining it to you and to everybody else. It is a ridiculously complex situation, but nonetheless, that's what we have, and it works. There are problems with it for sure, and there's need for healthcare reform. But why on earth would we collapse one arm of this operation in the middle of a pandemic? We're still now 6-7 weeks into this and still with the same unworkable situation. And the proof of that is that as of this past week, we know that there's only 1/3 of the hospital beds are occupied. And I think the other thing we're finding is that operationalizing this without a full complement of staff in the private hospitals is a problem. You need really all of the available consultants in the hospital to ensure the safe operating environment. Because it's not just a surgeon who has an expertise and goes in to do a particular operation. If that surgeon doesn't have other surgeons with different skill sets in the same operating theatre on the day, or at least a phone call away if there's a problem, then there could be an issue. And then medical problems arise on surgical patients all the time. So you need cardiologists and respiratory physicians and gastroenterologists and neurologists and other disciplines and experts to help you mind those patients while they're in our hospital. And in our case, 40 of the doctors can't work. So how can we possibly, even if we wanted to, easily and smoothly and critically, how can we safely look after these people when we don't have our full team on the pitch?
You mentioned that was it a third? There's just about a third capacity at the moment in the private hospitals.
Yes. Yeah.
But I've heard interviews with HSE people saying otherwise, that they're saying it's working well and that there is good capacity in the private hospitals.
Yeah, you'd have to ask them where they're getting those numbers, but the private doctors who are affected by this have gotten together as a group to try and deal with this situation. And one of the things we do on a daily basis is we go around hospital by hospital and we ask our colleagues exactly how many patients are in on a daily basis. So we have our set of numbers and we will stand over them, and that's where I say a third of the beds are occupied as best we can tell. If the HSE have different numbers, you'd have to ask them where they're getting them from.
So what are the implications now for patients with this standoff, particularly people who are in a very perilous situation like cancer patients, like your patients?
Look, I'm worried because we had to stop for 2 months, clearly, so that people could be protected from the virus. Then when we bring people back into the hospital, we know the operational procedures have to change, and in general they're going to get slower because we have to clean the rooms a lot more thoroughly. There's a whole issue around PPE or protective equipment that has to be incorporated in. There's issues around how anesthesia is done, because anytime you get near anybody's airway, there's a risk of aerosolizing the virus and therefore threatening the staff who have to look after these patients. So our procedures and policies are going to have to, the rule books are going to have to be rewritten. So for those two reasons, we've already lost a couple of months, and we have to have slower procedures which are going to have less throughput capacity. We're already behind the 8 ball, and that's why we say, look, get everybody back to work as soon as possible. So I'm worried particularly for cancer patients, but of course every discipline and every specialty has their own set of concerns here, because we know every day that a patient is not diagnosed or treated potentially worsens their outcome.
Now, we know that there's been a lot of focus on this particular situation over the last, particularly maybe the last fortnight or so, and politicians have been speaking out about it. The contract was only for a few months to begin with. Do you think now that maybe, given the pressure that has been applied on the Department of Health, on the HSE, that they will not extend this, or do you get a sense that this is going to be extended beyond the 3 to 5 month period?
Look, the truth is we don't know, and if we've learned anything about this pandemic is that things change on a daily basis. So we're in a very uncertain, we can't control obviously the virus completely, and so we're in an uncertain environment. And when you have things you can't control, then all bets are off. For the moment, the deal is for 3 months, which should end at the end of June. I and others who've argued about this privately and publicly hope fervently it will end at the end of June, but that's in the gift of the HSE. They have the right, as I understand it, to extend by a month, which will take it to the end of July. And I think with termination clauses, it might run to August. Honestly, the sooner it finishes, from my perspective, the better. They're not perfect, but we had, working arrangements which would be more efficient, and they predated all this. And if we can get back to them, I think we can pick up the pace much quicker. But we're in the hands of the government and the Department of Health on this. If they decide that because the virus is not well controlled, or other viruses like influenza get in the way, or any number of issues that could crop up between now and then, they could extend it. That, I think, would have profound and probably durable effects on the Irish health system. And I'm not sure that enough understanding is out there about the real costs of collapsing part of our health system right now. That was looked at in the past, and as I understand it, we couldn't afford it then. It's going to be hard to see how we can afford it now. So to answer your question, the sooner we get out of it, the better. And I'm only hoping that the politicians and the senior leadership in the Department of Health and the HSE will realise, although the idea was good, the cause was just at the beginning, the execution has been really lacking.
What would make you sign the contract if they took all your concerns on board?
That's a good question. At this stage, clearly the preference for me would be not to have the structure in place at all. Give us back the hospitals, they'll function better that way. But if there's an insistence on keeping this dual command and control system, which I think is problematic, then they could have picked either a different contract structure, which would essentially make us all private-public doctors and we could all work across all platforms. That would make a lot of sense. There are contracts like B and B star and C and various other designations that would have allowed that. There are other structures that would allow for public work to be contracted into the private health system, such as the NTPF or service level agreements. Those work fine.
You just want to see it ending, actually, and then...
There are other ways to do this. They picked the one that was likely to be the most disruptive, in my opinion, and that's how we've ended up here.
Okay, we'll leave it there. But Frank, thanks very much. I think we got through a lot more explanations of what is happening with this. It's very complicated. But Frank, thank you for that.